So the hypothesis of my study is outlier analysis using clinical and genomic profiling of small cell lung cancer patient population will identify biological drivers of outcome in this population. So the objectives are create a comprehensive clinical database of small cell lung cancer patients treated at Emory Winship Cancer Institute and Grady Memorial Hospital, compare the demographic and clinical characteristics of these patients, identify match outlier patients, which we define as the top 10% and bottom 10% of patients based on survival, and analyze the genomic differences between these clinical match outliers using next-gen sequencing techniques. So for those of you who never been to Atlanta, we have two major cancer centers, which is Winship, which is a private hospital, and we also have Grady Memorial Hospital, which is our county hospital. We treat two different populations, as you can expect. So this is the flow of my study. So far we have 579 patients since 1990 until 2014. Outlier analysis to identify top and bottom 10% of patients based on survival. Then we match for clinical prognostic factors, including age, gender, and first-line treatments. So we could come with 49 patients in our top survival and 49 patients in the bottom survival. So this is what we've done so far. So we have the list of 47 patients on the top 10 and 47 patients in the bottom 10%. So the next step, what we are going to do is do the genomic profiling using RNA and DNA sequencing. So this is the baseline characteristics of our study so far. As you can see, at Emory, we have almost 60% of the population. At Grady, which is our county hospital, we have 40% of the population. A little bit more males than females as expected. But what I think it's unique is we have an African-American population of almost 50% of our patients. As you can see, age, almost 60% were below 65 years of age. And the smoking, we know that small cell is very related to smoking history, more than 90%, but we only find that 63% of the patients were smokers. We think that this is like data collection, I think was like reported wrong on the chart. And the initial staging, almost 70% of the patients had an extensive stage. Regarding PCI, only 21% of the patients received PCI. We think that this number is low because PCI was just approved in 1999 and our data started back in 1990, so a lot of patients in our database did not get PCI. And what I think was interesting is almost 50% of the patients did not get any chemotherapy whatsoever. First line, almost 35% got one line of treatment, 9% got 2 lines of treatment, and only 6.6% of the patients got more than 3 lines of treatment. So this table shows the baseline characteristics, but now we broke down between the two hospitals, the private hospital and the county hospital. As you can see, as you can see here, the African American population here at our county hospital was 87%, with only 30% at Emory. So it's much more Caucasians at Emory than in our public hospital. African Americans, they tend to present a little bit younger. Regarding tissue, I think we were more aggressive at our private hospital than in our public hospital. And initial staging, as you can see here, almost 80% of our patients at Grady presented with extensive stage compared to 64% at our private hospital. So they present at more advanced. So these are the curves that represent the progression-free survival for all the patients, for the 579 patients. The 1-year PFS was, according to the literature, 25.3. The 5-year PFS was 7.6. So this would break down into different hospitals. The 1-year PFS at Emory was almost 21%, at Grady 32. The 5-year PFS at Emory was 5%, and at Grady was 13.1. So the blue curve here represents the patient at Emory, and the red curve represents the patient at our public hospital. This is the overall survival for the 579 patients. 1-year overall survival, 1-year overall survival was 33.5%. 5-year overall survival was only 4%. Again, here, you comparing the private hospital with the public hospital, the curves are superimposed, so no difference in the overall survival between the public hospital and the private hospital. This is the overall survival for patients that got PCI. The curve in blue here are the patients that did not get PCI, and the curves in red are the patients that got PCI. This is for extensive and limited stage. This represents the 579 patients. So as you can see here, the 1 year's overall survival for patients that got PCI was almost 80%, compared to those that did not get was almost 35%. The 5-year survival patients that got PCI was 20%, and no PCI was 4.1%. So a big difference there. So predictors of survival, we didn't find that race was a predictor of survival. We didn't find that age was. We found that white count, hemoglobin, and LDH are, according to the literature, predictors of survival. But we also found that PCI was the most dramatic predictor of survival, with a hazard ratio of 3.25. So ongoing work, so like I mentioned before, we're going to compare the genomic characteristics of the matched outlier patients within the top 10% and compare with those in the bottom 10%. And now we are going prospective data collection from all new patients diagnosed with small cell lung cancer. So this is a preliminary DNA mutation analysis that was done at Emory with 19 patients. We analyzed pulmonary and extrapulmonary small cell lung cancer, analyzing one of the 10 genes involved in small cell lung cancer. So even with the paraffin tissue embedded samples, we were able to detect these genes. This is the RNA sequencing as well from the pulmonary and extrapulmonary sites, and we were also able to do the RNA sequencing from this paraffin embedded tissues. And we were also able to do copy number analysis, which identify MYC as one of the most common amplifications in small cell lung cancer. So the conclusion is we have one of the largest single institution small cell lung cancer database. We have a unique population with 50% African Americans, 50% Caucasians. We didn't find significant difference in survival between African Americans and Caucasians, and we didn't find difference between our private hospital and our public hospital. Almost 50% of the patients did not receive any types of chemotherapy, and PCI showed its strongest association with patient survival. So I want to thank Dr. Wanikoka and Dr. Malingan for being amazing mentors. Mukesh is a colleague of mine that helped me with the data. And then we have the statisticians, Gabriel Sika and Rossi, responsible for pathology and genomics. And these are the medical students that helped me collect the data. Thank you.
So any questions? I have one. 50% of the patients didn't get chemotherapy.
Mm-hmm.
So what, do you have an explanation? Because even back in, back to where your database started, chemotherapy was pretty much a standard of care for even limited and extensive stage. So what's your...
I think a lot of our patients at Grady, they present like really late and very poor performance status. And a lot of them, we diagnose them right, like they were in the intensive care unit and things like that. So we were not able to give chemo even in that scenario.
And it looks like, you had rate PCI being a prognostic. You didn't have chemotherapy. Did you even look as chemotherapy as a prognostic?
No, we didn't look into that.
You didn't look into to see, because that'd be interesting to see also where the impact of, and then look at the chemo group in the same analysis.
Yeah, we have the patients, all the chemos listed, but we didn't do that. Yeah, that's a good idea.
Okay. Any other questions? All right, thank you.
Thank you.